inject something and cause more weight, does it cause strain on other muscles?
It can. So usually my target is not to inject the muscle. Okay, my target is not, so everywhere that there is a muscle, there is the skin that overlies it, and the skin overlying it has fat. So the skin of epidermis, dermis, fat layer, muscle. I want to baby the muscles you want to have. I don't want to do anything to it. So you're sort of kind of hovering around the muscle, trying to give it support. If you see any child, the baby's face is filled with fat. You can see a baby who is born who has facial paralysis, and the parents will tell you we didn't know he had paralysis till he was about a year old. It's because the full baby fat in the face just masks everything. So we are trying to simulate that same situation. As we age, we naturally lose fat. So you lose the fat, you're losing the support, and then the muscle can't support the face. So when we're doing the fat injection, we are not doing it into the muscle. You can, but usually I don't. I'm putting it in the fat layer to support the area. So fat, I like to use the fat because it's cost effective. I can get as much as I want, fortunately. Yeah. So usually the way it's done is we pick a side where we want to get it. You can get it from the thigh, outer or inner thigh. You can get it from the abdominal wall or the hand. And you anesthetize the area. So most of these things can be done under local anesthetic if we want to. So you anesthetize the area with the local agent, and you have a cannula that's about 2 millimeters wide, and you liposuction the fat. When you do, the fat is mixed with serous fluid and blood, and if you inject it, you're injecting things that you don't want. So you have to make the fat settle, or you spin it, and then when you do, you decant the fluid off, and then you transfer the fat into tiny syringes like that. And so you want to look, see yellow-looking fat, and then you start injecting it to where you want. Okay. So to show you examples of where we put fat, you remember I told you about the lower eyelid? I'm going to go back to that area a little bit. So you could put fat in the lower eyelid, and it will allow the lower eyelid that is pulled down to move up, so that white show will be less. So you can close your eyes better. Now in the lower eyelid, we are not putting it in the muscle. You can't even put it in the muscle because the muscle is paper thin. But deep to the muscle, there is natural fat. Short form, we call it the SOOF, suborbicularis, which is the muscle orbital fat, right? So you put it nappa, and it pushes the muscle up to give you a little bit vertical push so that the eye can close much better. In the same token, if you don't want to use fat, you can use the same hyaluronic acid that I mentioned about. So the idea is you're trying to give support and have things kind of move up to help things work better. The other area that we put fat is in the bassineter area. You remember I said in the cheek area, the muscle has lost tone. Fortunately, there is a lot of, there's supposed to be a fat compartment in the cheek area. We have a fancy name for it. So if I want to support that area, I put the fat. That has been the most effective way I've seen that people's speech improves. You know, I have seen people that I have actually taken measurements. So before you do anything, we can put a pressure measure between the lips and ask you to blow, and then see how much the pressure you can generate. And then after I do the fat injection, ask you to repeat it. And you can see like night and day, the pressure generation goes up. It's not a permanent solution. You know, you put the fat in, it improves, then maybe you lose some of the fat, then you have to add to it. All these are minimally invasive, so that's why I like them as adjunctive measures to help things. So you can put fat in the lips. I'm sure you've seen people who have blown up lips. That's not what we're talking about. We just want to support the areas that need support. So around the lip, if I want to inject or put any support, I will ask you to pronounce some words. Usually the P's, the B's are the difficult ones to put, what I call the plosive sounds, things that you have to generate pressure and keep the air in your mouth, and then the air escapes. You can't maintain the pressure. So we usually kind of gauge where the air is escaping, and that's where we put it fat, to kind of plump it up, not blow it up, plump it up, to get that support. Around the left, I also told you, if I find that the sphincteric muscle is not complete and you have a gap at the corners, we go transorally inside the mouth and open to see the separation between the two muscles, and then just suture the two muscles together to complete the circle. And that little bit helps. Everything I've told you about can be done under local anesthesia. Nothing invasive. Okay. So we've talked a little bit about the eyelid muscles. When you lose tone, this eyelid muscle pulls down, and then you see more of the white here. Again, this is an example of someone who has lost tone. Usually the eyelid margin, this margin is supposed to be here. So if you're seeing white underneath the iris, we call it ectropion. And we measure it based on the distance from the pupil down to the eyelid margin. So if I put the fat in here, this eyelid is going to go up. Okay. So that's one method of doing that. So the idea is we want to just get everything to go up. Another option is that we can tighten the eyelid. Okay, so it's pulled and you can stretch it and make it tighter. It's not my preferred procedure for someone with FSH, because I think it's a little bit more invasive. It can be done on the local, slightly more invasive. It requires you to do an incision. It's not my first choice. For any other reason, for eyelid drooping, that's usually one of the things that we do. I talked about using a filler instead of fat. Another thing I like is called the spacer graft. A spacer graft is between the layers of the eye. When you go from the skin, the muscle, then there's a septum over which the muscle moves, and then there's a space in which there's all this fat. Okay, you can put something that is stiff, flexible but somewhat stiff, into that space to force the eyelid to stick up. Okay, it's actually a procedure that I really, really like. So I use a material. I'm going to skip this. I'll come back to it. This is a synthetic material that we usually use to repair the dura. So during neurosurgery, if there's a defect in the dura, you use it to repair the dura. It's a collagen matrix. So if I put it anywhere, it's stiff like that. When I put it anywhere, it becomes flexible, and the body grows tissue into it, and it forms this fibrous layer, and it gives a little bit more support to the lower eyelid. Okay, I use this for any reason for lower eyelid paralysis, and for FSH is a good option. I've tried it before. Yes.
Does that have any kind of rejection problems?
No, I haven't seen any. So it doesn't have any living cells in it. So if it has a living cell, then you have the potential of rejecting. It's only acting as a scaffold into which your tissue can. Scar is stiff. So in essence, I'm trying to create a controlled scar in a layer of the lower eyelid to help give it a little bit more support. This procedure has been done for ages, but in the past, the way it was done is that you take cartilage from the ear and you put it in the eyelid. If you do, your eyelid will move right up, but the cartilage is too stiff. So sometimes you can see it. This actually looks like paper. If you put it in water, it becomes very soft, and it just lays down in the lower eyelid, and then tissue grows into it and gives a little bit of substance to the lower eyelid to give some upward mobility and a little bit more support. So I like this. I'm going to go back to one other option that I like. Another option is what I call the fascia sling. So a fascia is tissue that usually lays over muscle. If you take a string of it, you can thread it under the eyelid margin, and just pull the eyelid hole up like a curtain, like you're hanging a curtain, which is what the lower eyelid is. The lower eyelid is a curtain, but the curtain is kept up by a muscle. And if the muscle has no tone, the curtain just drops. So occasionally we'll just do this procedure and fixate this fascia on the inner corner and the outer corner to give some upward mobility. Yes.
Does this help push the dryness in the eye?
Could you repeat that?
Does it help with the
Procedure help with the dryness of the eye?
Okay, so the reason why the eye gets dry is not because you're not making tears. You're making a normal amount of tears, right? But anytime we blink, you spread tears over your eyes to keep a layer of tears just protecting the eye. If you don't have an effective blink, like the wiper windshield screen, the tears you make just evaporates off. The tear gland is out here. It has to make it all the way to the inner corner. So you are not getting an effective spread of the eye. Listen. So when you bring this upper eyelid up, if there's a little bit movement on the if you bring the lower eyelid up and there's a movement on the upper eyelid, then you have a more effective blink to be able to spread the tears. In some people, when you lose tone in your lower eyelid, the eyelid kind of pulls away from the eyeball. So you will see a gap between the eyelid and the eyeball. So they will tell me they are tearing all the time, as I said, they are crying all the time. Okay, it's because the tears just pulls there and has nowhere to spread over the eye. If you do this, it pulls the eyelid back over the eyeball, so you can have an effective blink.
Does this also help with the strength of keeping the eyelid closed?
It helps with the eyelid closure. It's not a dynamic thing, because it's not muscle, it's not innervated. It's just bringing two muscles that are somewhat working closer so they don't have to work that hard. Okay. Good. So this patient here has paralysis from a different reason. So completely paralyzed, and you can see this is the left normal eye. You see where the iris is and where the eyelid is, and when you come to the paralyzed side, there's a gap, and then this is when after you put the sling in, and it goes up. So now he can blink and have a more effective blink. Okay,
And Dr. Boahene, when
Yes.
you go back to that picture, the left eye, or maybe it's the right eye, looks smaller. That will come down because that's probably taken after it's swollen, right?
This eye, yes.
Yeah,
Yes.
okay, just so people know that.
Yes. Okay, so I talked about the fascinator muscle for the trumpets. You can't really replace it. The best thing I have found is the injection in that space with something that sits over the muscle. The idea is that if you have tone in the fascinator muscle and you need to generate pressure for a plosive sound or to blow a medicine, this muscle gives you some resistance. So if it's flaccid, it's lost tone, it just balloons out, it doesn't generate that pressure. So if you fill the buccal space, which is naturally with fat, if you fill it with fat, then it gives you some resistance and helps with those plosive sounds. We've talked about this. So my idea about tone, which is one thing, is to support it with injection of some substance, be it your own fat or synthetic material like the hyaluronic acid. There are some other synthetic materials that are more permanent. I don't like any synthetic material that is permanent in the face. I just don't, because if something goes wrong, you are dealing with something that is permanent, and you have to go surgically get it out. And besides, if technology improves and we have something better in 5 years, you are stuck with the 1980 product. So we want to move with the age. The other thing that happens, so those are tone, getting tone. Sometimes muscle has to do the work. You can't replace muscle with anything else, and sometimes muscle has to do the work. We do have options to move muscle from anywhere in the body to the face. And I actually spoke to Dr. Wagner about, I asked him, so how about the shoulder muscle? How about the serratus? How about it? And I was disappointed to hear all those muscles get affected. But the muscles that I have observed, and from my reading, doesn't seem to be affected. One of them is the temporalis muscle. So this is the function of the normal temporalis muscle. If you want to push your jaw out or close your jaw, it's what pulls the jaw closed. Again, there are other muscles called the pterygoid muscles that tend to do the same thing. So you can lose some of your temporalis function and still do fine and doesn't affect you. And normally that temporalis muscle starts from here and goes down and attaches to the jawbone. So if you grind your teeth or you try to bite down, you feel the temporalis moving back and forth. That's the first test. I want to see if you have it and if it's functional. That muscle is a very big muscle. It's triangular shaped. And we arbitrarily divided into 3 parts, the first third, middle third, and lower third. You can borrow a portion of it, and the remaining portion will still function very well. So if I want to improve tone in the cheek area without having to deal with injections, what I could do is just take a portion of the middle muscle and drag it down and it sits in the same area where the bassineter muscle sits, and it gives you the tone that we want. But in addition, it can do more. You can use it and then connect it to the corner of the mouth, so that if you want to smile, if you don't have any movement in the corners of the mouth, and you now want to smile, if you smile and do that Mona Lisa smile, trying to think of biting down, then this moves. Okay. It's been tried, it's not a new thing, it works very well in all situations of paralysis, but adapting it for this situation, I think is a very effective. I don't commonly do this procedure, this particular procedure for facial paralysis in general, because there's something that I think is better. And at Hopkins, we sort of tweak the approach. I will show you an example of that. But for FSH, this may be an ideal procedure. And I'll explain why. The reason is that it does two things. One, you have the muscle sitting in the area where the bassineter is supposed to be, and it gives you the tone in the cheeks, besides giving you that potential movement on the corner of the lip. We've talked about the injection already. So this is the shape of the temporalis muscle. Now, I told you I don't do this as much, but it may be ideal for FSH. What I do more of is what we call the muscle tendon transfer. So for me to do this procedure, I have to make an incision over the scalp in the hairline to find this muscle. But I can do the same thing if my only goal is to get you to smile, you don't have any problems with blowing things and maintaining your bassineter. If the main goal is for me to get the corners of the mouth to turn up and get you movement with smile, I prefer not to make any cuts on the outside. I can go just straight through the mouth and go find the tendon of this muscle, same muscle, and that's it. This person is just going through the mouth. And then you can move that tendon to the corner of the mouth, and then when you smile by biting down, the whole muscle moves. In this, it's a very straightforward, you don't have to make any external incision. So that's why I prefer to do this procedure if the goal is just improve the smile or improve some expression on the face, and not so much of kind of maintaining tone in the cheek areas. It does give some tone in the cheek areas because this tendon still has to go over where the bassineter is. But comparing this, I'm going to go back. See? Okay, so if my goal is to give more tone to the cheek area, bringing the ventral portion of the muscle over the cheek is more effective. But if it's just to really get movement, then I like to bypass making all these external incisions and just go straight to the tendon and move it to the corner of the mouth. And that is this example, right? Okay. So this is an example of someone who had that done. So there is no tone. You see how the corner of the mouth just drops, this side of the face moves down, and this is after you've done that procedure. Now if I ask her to smile, this side will move.
Now with this patient, Dr. Boahene, was that like a paralysis?
This was a complete paralysis.
Yeah.
So there is just nothing at all.
Okay.
Complete paralysis.
So would that be similar to somebody that has lost all their facial muscles
Yes.
because of?
Yes. So you can use it for someone who has partial weakness. So not complete, but you just want to augment what they have. You want to preserve what they have, but you want to add to it. So you can do that, or you can do it for somebody who's totally completely gone and there's just nothing. Okay.
So with the woman that you showed, that was just the tendon that you changed?
Just the tendon.
So if you did the tendon and then also did the fatty injection in there for foam, would you get all the benefit then, right?
You will.
Yeah.
You will. Yeah. Yes.
Is there a mental retraining to get the wrong muscle to do the right thing?
Yes, there is. So I call it the temporal smile. Temporal smile, because the muscle is the temporalis muscle. And once you do that surgery, the first week I'll tell you, don't try to use the muscle, because you just detach a tendon and connected it somewhere else. You want the attachment to kind of solidify before you start moving it. And then the next week, you go on soft diet, nothing that you have to chew too hard. And then the third week, we start deploying that muscle. And you always need some feedback. You know, if you put your hand here and you start biting down, the original motion, you will see and feel the muscle move, and then you see and feel the corner of the mouth move. Now, we have physical therapists who help with this, kind of teach you how to do it. And as you repeat and do it, it becomes second nature. You just do it without thinking about it. Okay. This person had congenital paralysis. So he was born with no movement on the right side. Okay, so
His right or our right?
her right.
Okay, her
So
right.
this side. Okay. So she could not close her eyes completely. She closed with a gap. I have done that spacer graft that I put in the lower eyelid for it to go up. And I have done that tendon transfer. There's no cut on the other side. So now I'm asking her just move this side and now move this side by biting down. And then you can see. Initially, when you do this surgery, it looks like it's overpulled. You see an indentation because the muscle goes into spasm and really pulls it, and then it starts relaxing, and then you start using it. I usually can check before the person wakes up that they are smiling because you can stimulate the temporalis and see how much movement. Muscles move, we have what we call muscle tension excursion curve. If you put too much tension, it's not going to move. If it's flaccid, it's not going to move. It just has to be just right. So when we release the tendon, we stimulate the muscle and adjust the tension till we get the maximum movement that we want. Then I connect it at that tension. If, let's say, for some reason, after the surgery, a year later, they tell me it's too tight, I just go back and release it a little bit. Or is it too flaccid? You can tighten it a little bit. Yes.
Are these procedures covered by insurance, or is this considered cosmetic because it's smiling?
You know, insurance, they will always consider it something they don't want to pay for it. We have to make the argument for it. Cosmetic reconstructive, they overlap all the time. For me, we are trying to restore function, try to help with tone in the face, so that when you're drinking, you are not leaking out of the mouth all the time. So when we are doing this particular procedure, it's considered a reconstructive procedure. Obviously, we can make you look better from it. It's important as well. But I consider it as a reconstructive procedure, and I haven't had issues with that. I think that's my last slide. So in summary, we are looking at trying to improve tone and restore some movement. And with tone, we are talking about tone around the eyelid, focusing on the lower eyelid, tone in the cheek area to help you can maintain pressure when you are saying plosive sounds, tone around the lip, also for lip seal. Movement, if we can get it, movement has to have some muscle, and usually the target muscle, as far as I'm concerned now, is the temporalis. The masseter muscle is the second muscle that I told you that we don't think is affected. Most of these muscles that I'm talking about, you are not cutting the muscle and discarding it, you're just moving it from one place to the other. Okay, the masseter muscle can be used for the same thing, but the vector of the masseter muscle is not ideal. So I prefer to use the temporalis muscle. Yes.
Since you're taking some of the existing muscle, it's not going to be there to do its original function. So do you get a trade-off, where the chewing and things like that?
Yeah, I have not seen any effects whatsoever. Again, so when we take a strip of the muscle, we are not taking the entire muscle, we take the middle third, so the anterior and posterior thirds. The three sections of the temporalis muscle have somewhat different functions. They tend to overlap. But when you take the midsection, I have not seen any deficit in terms of you can open your jaw, you can close your jaw, you can chew. In fact, for patients who have cancer patients, sometimes you have the temporalis on both sides taken out completely, and they still compensate well. Now, for someone with progressive muscular problem, you have to be very careful. You have to make sure that the other muscles function very well. The muscles that are very critical for mouth opening and closing are the pterygoid muscles, and they are deeper, and those are not affected. Yes.
The effects of this are permanent?
The effects of this are permanent. Yeah. For you to get a permanent, you have to have a muscle that stays alive, that doesn't degenerate, right? And it's still attached to the new target to which you put it. So the effects are permanent to the extent that the attachment is still there. I have had some people that have had to revise, meaning that where we did attachment, and they have movement, they don't have enough movement like I want, and so we just go back and find the tendon and make it tighter.
So is there a lifespan on the surgery, like 10 years, 20 years? Does
So-
it get, what time getting used?
The thing that you see with time is that it becomes more spontaneous. This is a learned, acquired thing. You're using the muscle that normally doesn't help you smile, and you're using it for different things. So over time, as you use it, it should get better. But to answer your question directly, it's part of you. As long as that muscle is not affected and become progressively weak, and barring aging changes, it should still do the new function that we've given. Now we know that when you move one muscle from one place to another, when it starts doing a different part, certain things change with that muscle at the molecular fiber level. Is that enough for us to see a change in what we are doing? Not that. This is a procedure that has been done from the surgeon who described it is called McCarthy. This is from 1940 something. Yeah, it used to be done with a bigger incision. So to move the tendon, you see I went through the mouth. That is a Johns Hopkins tweak to that procedure. And originally, it's an incision that you have to make here, take the jawbone out, find the tendon, cut it, bigger surgery. And we said, no, we don't need to do all this to get there. So we just go through the mouth. And so that's the tweak of Johns Hopkins Stanford procedure. Yes.
Could you say more about, you mentioned the muscles that control the nasal passages, and I've had a long problem with that, and nobody has ever given me any sort of an answer.
Okay.
And I wind up, my problem is lack of air.
Yeah.
Not necessarily muscle strength when I'm working very hard. And
Okay.
the same thing overnight breathing, I wind up with my mouth open.
Okay. So I'm going to answer your question specifically as far as that muscle is involved, and maybe expand beyond it a little bit. So the nasalis muscle is not really used at rest as much. So you don't see anybody breathing quietly and your nostrils really flaring. So at rest, if you are having problem really taking it easy, there's something more than just the nasalis. When you start exerting yourself is when you see that nostrils really dilating to get in, right? So in those situations, if you're not getting enough air, it's just because something is collapsing. Everything I mentioned, I've never said anything about that muscle, right? But there is a simpler solution for it. It doesn't need an injection. It doesn't need a muscle transfer. In the nose, we need to put something stiff that will keep the nose open, and usually it's cartilage. So the solution for that is simpler than everything else I've said. Usually you can get cartilage from the ear, it's got some curvature to it, and if you put it in the area where that muscle is, it will open the nasal passage and you get airflow.
To expand on Jim's question, could that cause a constant runny nose right through here?
So anybody with the FSH will be prone to the same thing that the general population is prone as far as nasal problems. So you want to make sure that those two things are separated.
Yeah.
So running nose could be from a whole different things. We make about 1 liter of mucus every day. If you want about 1 liter of it, okay? But we're not drowning. It's because whenever you take a breath, the air picks up the moisture from all the stuff you're doing, and the air has the moisture before it goes into the lungs. If anything changes, then you start having runny nose. Either something inflaming the nose and it's making it a little bit more, or you are not. And in addition, we swallow some of them without even knowing. It just kind of goes down, you swallow, you don't think about it. If the consistency of that mucus changes, you start complaining, I have postnasal drip, I'm feeling. So something has changed. And sometimes it's just the way the air flows. So if you're not getting a really laminar airflow through your nose and the air is just going to whirl around, it's going to dry the mucus. You will feel and sense that mucus is moving around, and you start complaining, I have runny nose, or I have postnasal drip. So it could be just that the nose is obstructed, the air is not moving very well. But as far as that muscle is concerned, if that is an issue because of the weakness, the solution is that you support that area with cartilage.
So there are 48 people currently watching the stream online.
Okay,
They're loving the presentation.
great.
There are two related questions. One person is in the UK and would like to know if there's anyone doing this procedure in the UK, and the other related question is how many doctors in general across the US are doing this type of procedure.
Okay, so our specialty focuses on head neck, and most of these things are published things. It will be known to be done for paralysis in general, but when I get to publish a paper saying this can be used for FSH, people will start making that connection. But the know-how, the technical know-how, surgical skill is there. I've given lectures about transferring that tendon because I actually described it at Hopkins. So I've given lectures in Europe, including in Europe on this technique. So there are people who can do it. It's in the literature, they can do it. There are a lot of people who can do that procedure. It's just you have to understand that you're taking something that we normally use for something else and tailoring it for this particular process. Across the US, I can't give you a number, but Hopkins used to be known as the place to do temporalis tendon transfer. The tendon transfer, if you Google that name, Johns Hopkins will follow it. But now it's becoming the norm. So there are centers around the country that does it.
What are some of the things, I'm sorry.
I was just gonna add a caveat to the people who might be watching. I think that it's really important probably for this, and also, just like any surgery for muscular dystrophy, like scapular fixation, that you find a surgeon who actually really knows FSH.
Yes.
That I was just about to say, thank you. Yeah.
Next question.
Yes.
Would you recommend before you did any of the fusions that they try doing some of the filling techniques first?
I think, especially if you're, most facial plastic surgeons will be very new to this. I have not seen a single publication on FSH in our literature, not a single one. So most people will be very new to this. And my recommendation will be to follow the steps that I sort of did. And Dr. Wagner is very protective of her patients. And she's watching. Yes. Yes. And that's the approach that I think everyone should take. If you want to see, is this going to be helpful, you start with maybe fillers that are reversible, short-acting, around the lip, know where you're putting it, see the effects. When you like the effects, you said, okay, we like the effect, it doesn't cause any problem. Maybe we can use something that lasts a little bit longer. So in a graded fashion until you gain more, some experience, and then move from there.
One more question for Laura. On the grafting, that's when you actually do the surgery with the filler, the transfer, is that correct?
So a graft is anytime you take tissue from one place, disconnect it from its blood supply, and move it somewhere else. So if I take fat from one area and put it somewhere, that's a graft. If I take fascia from one area and put it somewhere, that's a graft. If I use a filler, it's not living tissues. No, I'm not really grafting, I'm just filling. Okay, so one is more, it's just a technical thing, they're trying to do the same. A flap is when you're taking a living tissue that is connected to its blood vessel, moving it from one location and just taking it to another area. So the temporalis muscle that we flip down is a flap.
So like what you did with me, when you moved it or whatever you did, is mine gonna be permanent and I just,
Permanent.
okay, and so I'll just continue
You use it
to catch up?
and make it more the same. So this is with the understanding that I am thinking with my limited observation, reading experience, that temporalis muscle is not affected with this disease. And I looked and I looked and I looked and I've seen all the muscle groups in the literature and online. It always maps out temporalis masseter, and then the pharyngeal muscles are excluded in this disease. Nobody has seen. Obviously, there may be people who are outliers, but in general, if I ask you to kind of bite down, I'm seeing this muscle moving, and we take a biopsy and we compare it to other muscles and we're not seeing features that shows that this is going to be affected. then you should expect that result to be long lasting.
So when you said like if you transfer like out of the cells, like 10 of them, 5 of them will live, out of those, say 5 of them, those will last forever, those are permanent?
Yes. Oh, you are talking about the fat graft. So
Right.
the fat grafting is the success of it is technique dependent. We are getting so when you're taking fat from one area, it's happy where it is. You're moving it to another area. You're stressing it. You're putting it in a new home. You have to make it happy. Meaning, the technique of taking it out should be very atraumatic. You have to baby the fat. Make sure you don't traumatize it. Put it in another area. Make sure blood vessels get to it. So it's technique dependent. And in my hands, usually I see 50% survives. When they survive, they have a new home. They are there forever.
Oh,
Yeah.
thanks.
Okay. Thank you very much.
And